Hello everybody. Today we are going to discuss about chronic obstructive airway disease. So acute exacerbation of the chronic obstructive pulmonary disease is defined as an event in the natural course of the disease which is characterized by the change in the patient's baseline dyspnea cough sputum that is beyond normal day-to-day variation, which is acute in onset and may warrant change in regular medication. So risk factors for acute exacerbation of COPD is history of prior exacerbation, history of hospitalization for prior exacerbation of COPD, elderly, duration of underlying COPD, mucus hypersecretion, presence of other comorbidities such as cardiac disease, diabetes mellitus, pulmonary hypertension. Infectious etiology of acute exacerbation of COPD, like viral infection and bacterial infection. Viral infection include rhinovirus, respiratory syncytial virus, influenza virus, parainfluenza virus, coronavirus, and bacterial infection include H. influenza, Moraxella, Streptococcus pneumoniae. Then regarding pathophysiology, the hallmark of COPD is airflow obstruction limitation measured by forced expiratory volume in 1 second to forced vital capacity. And the ratio between FEV1 and FVC is less than 0.7. Emphysematous parenchymal destruction increases the lung compliance and that leads to the early airway collapse. There are a variety of theories underlying the changes in the lung, but it is generally accepted that they are the result of the host factors and the exposure, that is chronic innate and adaptive inflammatory immune response of the host to lifetime exposure to the environmental factors such as inhaled toxic gases and particles. As the lung ages, if we want to deteriorate from about the age of 35 years onward at the rate of 25 to 30 ml per year in normal individual and at accelerated rate in the susceptible smoker at rate of about 60 ml per year. People with normal rate of decline can develop COPD if they have achieved the low peak level of FEV1. Symptoms are usually absent until 40% of FEV1 has been lost. The airflow obstruction of the COPD is caused by pathological changes in the small conducting airways, that is less than 2 mm in diameter, that contribute about 25% of total airway resistance in healthy individuals. The changes include disruption of the epithelial barrier, mucus gland hyperplasia, goblet cell metaplasia that result in the accumulation of mucus plug in the lumen of small airways, infiltration of the airway wall by inflammatory cells, and smooth muscle hypertrophy, peribronchial fibrosis, and deposition of connective tissue in airway wall. The changes in the airway wall result into the reduced cross-sectional area and impair the ability to increase caliber with lung inflation and have been correlated with the disease progression from gold stage 0 to gold stage 4. Emphysematous lung destruction is associated with the similar inflammatory infiltration of alveoli and the airway wall that causes abnormal dilatation of airways distal to the terminal bronchioles, perforation in the alveolar wall, and obliteration of the airway wall that coalesces to form bullae, destroying large volume of the lung tissues. This lead to the both loss of lung elastic recoil and loss of anatomical tethering of small airways. Emphysema have been subtyped depending on its pattern of distribution in the lung. The centrilobular pattern of emphysematous destruction usually has upper lobe predilection and is closely associated with cigarette smoking, and the pan-acinar pattern of emphysema is usually more marked in the lower lobe, and it is characterized by the more uniform involvement of the acinars, and it is associated with alpha-1 antitrypsin deficiency. The respiratory failure is the combination of lung failure as well as pump failure. Lung failure refers to the destruction of the lung unit alveoli vascular bed, leading to the reduced ventilation perfusion matching and shunt. Pump failure results into the mechanical disadvantage owing to the increased workload, impaired chest wall and respiratory muscle performance, and impaired central and peripheral motor neuron function. During acute exacerbation of COPD, inflammation within the lung causes dynamic changes to occur. Increased bronchospasm and mucus hypersecretion results in further narrowing of the airway lumen and airflow limitation. Hypoxemia, anxiety, increased metabolic rate, and acidosis lead to increased respiratory rate that shorten expiratory time and result in increased end expiratory lung volume. This results into the airway trapping, which when extensive leads to the dynamic hyperinflation. The increase in the end expiratory lung volume produces positive alveolar pressure known as intrinsic PEEP. This intrinsic PEEP can be associated with cardiac compromise, increased barotrauma, and alter hemodynamic pressure profile and cardiac performance. Dynamic hyperinflation leads to the suboptimal muscle length to tension relationship and mechanical disadvantage for the muscles of respiration. These changes induces severe dyspnea, increased dead space fraction, aggravate relationship resulting in hypoxemia, and when severe hypercapnia. Resolution of exacerbation and improvement in symptom correlate well with improvement in FEV1, inspiratory capacity, and reduced end expiratory lung volume. So regarding severity scoring, the grading of severity of airflow. So the gold stage 1 is mild, that means FEV1 is more than 80%. Gold stage 2 is moderate, that is FEV1 is less than 80, but more than 50%. Gold stage 3 is severe, that is FEV1 is less than 50 and more than 30. And gold stage 4 is very severe, that is FEV1 less than 30%. So this is the DECAF score, and it includes very variables like dyspnea, eosinophilia, consolidation, acidemia, atrial fibrillation. Total DECAF score is 6. If DECAF score is between 0 to 6, that means low risk. If DECAF score is between 3 to 6, that means high risk. Now regarding investigation, full blood count, that is WBC and differential count, can help in differentiating between the infective cause from the non-infective cause. Eosinophilic count can help in prognostication. Sputum culture sensitivity and viral studies for suspected infections help to identify those requiring antibiotics and antibiotics. Then regarding serum biochemistry, dyselectromia is associated with hypoxia and hypercarbia and worse outcome. Most of the patient will have hyponatremia, hypokalemia, and hypomegalia. Regarding ABG, to characterize, ABG helps in characterizing type of respiratory failure, ventilatory status, severity of exacerbation, and ongoing monitoring of the patient. Regarding CRP and PAPCT, it helps in assessing inflammation and may be able to differentiate bacterial cause from the other. Chest X-ray will help in assessing cardiac size, pulmonary edema, pneumonia, pleural effusion, pneumothorax. ECG will identify old and new myocardial ischemia, ventricular hypertrophy, and arrhythmia. Echo will be used to assess biventricular function, right heart dysfunction, regional wall motion abnormality. Troponin will with the help of troponin and BNP. If it is raised, then it is a suggestive of cardiac injury and cardiac stretch. It can a CT scan will assess the pleural and parenchymal pathology. Regarding antibiotics and biomarkers, overuse of antibiotics in ICU is common, which accelerate the development of the drug resistance. Quality ICU care involves judicious use of antibiotics. The reduction of antibiotic prescription rate has been shown to reverse the occurrence of nosocomial infection and drug-resistant organisms. However, the importance of antibiotic can be highlighted by the fact that mortality rate for patient in septic shock increased by 7% per hour within the first 6 hours of delayed antibiotic administration. Patient with sepsis from ventilator-associated pneumonia who had delay of more than 24 hours then after diagnosis until initiation of antibiotic have sevenfold higher mortality rate compared to those started on adequate therapy early. Systemic reviews of COPD exacerbations suggest that antibiotics have large and consistent beneficial effect across the outcome of the patient admitted to ICU. They have not been shown to be as useful in mild to moderate exacerbation of COPD. Recent strategies to reduce the antibiotic overuse have included the development of biomarker-directed treatment algorithm, where antibiotics are given or withheld depending on the level of biomarkers measured in the blood. Biomarkers that have been studied are highly sensitive C-reactive protein and PCT. PCT is currently most promising. PCT-guided therapy has been effective for reducing antibiotic use by approximately 40 to 50% in hospitalized patients presenting with lower respiratory tract infection symptoms. In all those randomized control trials, there was no increase in adverse effect among patients who had antibiotic de-escalated. Then regarding management, first one is oxygen. All the patients with COPD exacerbation have potential to develop hypoxemia and hypercapnia. We recommended the arterial blood gas to assess the degree of hypoxemia and hypercapnia. So supplemental oxygen therapy should be administered to patients suffering an exacerbation of COPD to maintain oxygen saturation between 88 and 92%, being careful to avoid hyperoxemia. Avoidance of hyperoxemia is important because of well-described occurrence of worsening hypercapnia. There is evidence to show indiscriminate use of oxygen therapy increase mortality and need for intubation. The induction of hypercapnia through hyperoxia is still poorly understood. It is thought to be combination of mostly change in mismatch with a mild decrease in central respiratory drive and Haldane effect. The ability of lung to shunt blood away from areas of low alveolar oxygen tension is disrupted by administration of high level of oxygen, and the resultant change in matching lead to the increase in dead space. The Haldane effect describes the binding ability of the oxygen for CO2 as increased the oxygen shift, the oxygen CO2 dissociation curve to the right and lead to the increase in partial pressure of arterial CO2. Patients who are already ventilating at their maximum capacity are unable to increase minute ventilation further to counteract this. High flow nasal oxygen devices are increasingly used in critical care. There is growing evidence base for their hypoxemic respiratory failure, but this form of oxygen therapy has been poorly studied in hypercapnic respiratory failure. One of the benefits of high flow oxygen system is the washout of CO2 from anatomical dead space and effectively converting oropharynx and conducting airway into a reservoir with high flow rates, delivered matching the patient's inspiratory flow more effectively. There is also a small amount of peak delivered to airway that can recruit lung unit or potentially offset intrinsic peak. Probably the greatest benefit is reduced respiratory rate that leads to the raised airway tract. Evidence for the use of high flow oxygen therapy in severe COPD or hypercapnic respiratory failure is limited mainly to case report and small study on exercise capacity. Regarding bronchodilator, patients in acute exacerbation of COPD have increased expiratory flow limitation. So nebulized short-acting bronchodilator are used to reduce bronchospasm. These medications have not robustly studied in severe COPD exacerbation requiring critical care. Beta agonist, short-acting beta agonist including albuterol and levoalbuterol. These drugs are selective beta-2 receptor agonists that induces smooth muscle relaxation and relief of bronchospasm. They can be administered via inhaler and by nebulizer. Common side effects include tremor, tachycardia, and hypokalemia. Now the next drug is anticholinergic. The short-acting anticholinergic ipratropium bromide block muscarinic acetylcholine receptor, thus promoting smooth muscle relaxation and inhibition of mucus secretion. These medications improve lung function and partial pressure of arterial O2. Common side effects include dry mouth, nausea, tachycardia, sedation. There is concern that nebulized anticholinergic may precipitate worsening of glaucoma by coming into contact with eyes in susceptible individuals. In general, we use combination of nebulized short-acting beta agonist and anticholinergic. Regarding antibiotic is an intervention that is often proven benefit in acute exacerbation of COPD requiring ICU. One must take into account the potential pathogens, local resistance pattern, and antibiotic stewardship. The most common bacterial pathogens are Haemophilus influenza, followed by Streptococcus pneumoniae, Moraxella catarrhalis, Pseudomonas aeruginosa, and common viral pathogens are rhinovirus, influenza virus, and RS. Regarding antiviral, viral infection, in particular rhinovirus, account for approximately 30% of COPD exacerbation, and variety of potential therapeutic agents have been investigated. Unfortunately, although the neuraminidase inhibitors such as oseltamivir and zanamivir are effective against influenza, and antirhinoviral medication have failed to demonstrate a clinically significant benefit. So we do not routinely test for viral exacerbation outside the influenza season. Regarding steroid, corticosteroids are routinely used for treatment of COPD exacerbation. The evidence for the use of corticosteroid for COPD exacerbation is explorated from studies of individuals with milder disease. To further confuse this picture, there is now evidence to support the use of systemic steroid in severe pneumonia and often coexisting diagnosis and exacerbation of COPD. So we know corticosteroid speeds the recovery of FEV1 and FVC in conjugation with bronchoalveoli. Corticosteroid reduce the length of hospital stay and the risk of treatment failure in first 3 months. Clearly, some patients respond to steroid therapy and some do not, and this probably reflects underlying inflammatory profile. And this Bafadel et al. Showed peripheral blood eosinophilic count as promising biomarker to direct corticosteroid therapy during COPD exacerbation. The most appropriate dose is unclear and is generally at discretion of the treating physician. The dosage should be cut down once a therapeutic response is evident and converted to oral once patient is able to swallow. For patient admitted with very severe COPD exacerbation, we use methylprednisolone 40 mg every 6 hours, consistent with original study, which was published by Albert et al. Regarding Heliox, Heliox is the mixture of variable concentration of helium and oxygen. That is 60 to 80% of helium, 40 to 20% of oxygen that has low density than oxygen and nitrogen. At lower density gas, it can improve flow in larger airway where airflow is turbulent and relative to laminar airflow. The increase in flow acts to decrease the work of breathing. In COPD, the addition of Heliox to NIV decreases the respiratory effort and intrinsic PEEP, but does not improve outcome such as requirement of intubation and mortality. We do not routinely use Heliox in the treatment of patients with acute exacerbation of COPD. In further lecture, we'll discuss with ventilatory management in the COPD. Thank you.